Well, welcome to the second episode of our digital dentistry webinar series. Today's episode is Identifying Pathology While Treatment Planning. Our guest speaker, Dr. Brandon Koroni, will highlight some of the most common radiology workflows for us. My name is Amanda Sellover, and I'm an application specialist here at Osteoid. And I'm going to kick us off by briefly introducing you to our company and today's guest speaker. For those who aren't familiar with Osteoid, we are pioneers in the dental 3D imaging space. Our in vivo software was created in 2004 under the company name Anatomage. Since then, in vivo has become the standard in 3D dental imaging. With increasing usage of CBCT imaging, having the proper tools and knowledge to interact with the data acquired is imperative. That's why we're joined today by Dr. Brandon Koroni. Dr. Koroni earned a doctorate in dental medicine from Midwestern University, Arizona, and subsequently a certificate in oral and maxillofacial radiology and Master's of Science degree in oral and maxillofacial radiology from the University of North Carolina, Chapel Hill. Go Tar Heels. In addition to specialty practice in radiology, he practices general dentistry as a private practice associate and with the United States Army National Guard. He is a member of the American Dental Association, Academy of General Dentistry, and Academy of Oral and Maxillofacial Radiology. Prior to pursuing dentistry, he did serve 4 years in active duty with the U.S. Marine Corps. Thank you for your service. Before I hand it over, there are a few housekeeping notes to mention. We will have everyone muted during the webinar. Feel free to jot down any questions you have in the Q&A box, and we'll save some time at the end to get to those. And without further delay, I'll pass it over to you, Dr. Koroni.
All right, everyone should be able to see my screen right now. Well, good afternoon, everybody, ladies and gentlemen, and probably good morning to some of the people out on the West Coast. Excited to be here on Friday and hopefully give a little new knowledge or refresher on a couple of things going on with radiology. I have nothing to disclose. I'm not an employee of Osteoid. I'm a general dentist, as she said. Even though my main specialty is radiology, I still enjoy getting opportunities to extract teeth, get people out of pain. That Friday night at 9 o'clock when you get a broken endomolar treated tooth that hasn't been crowned and it broke 6 months ago. So those are always exciting cases to get. But first, I'd like to acknowledge at least UNC. This is, most of the cases are coming from there when I was a resident there, as well as Osteoid for giving me this opportunity to really present this case, and White Furrow, which I kind of consider our radiology Bible. Also, a huge shout out to my father, who just turned 66 this past Friday, and a first-year endo resident at University of Maryland, which is pretty awesome. And the nice cherry on top is that my co-resident who graduated with me is also the faculty there now. So, that one Christmas gift I didn't get, I told Dr. Parsa to give him a low pass grade on something. So the agenda, we got a lot to cover within this hour. These courses are usually like 8 hours long, and I really wanted to touch base on a few different things. And hopefully, if we get some feedback on certain areas that you are more interested in, we can start doing a series on focusing more on the different types of categories or anything that's involving with radiology. So first, we're just going to talk real quick about the AOMR position paper on CBCT. We'll go through some anatomy through the CBCT scan, some applications for CBCT, some implant planning, and especially some areas of concern why we stress the importance of utilizing CBCT. Language of interpretation, and some disease categories that and then some cases, and at the end we'll do a little poll everywhere to get some interaction. So first, the American Academy of Oral and Maxillofacial Radiology, their executive opinion statement on performing and interpreting diagnostic cone beam computed tomography. So these are just some bullet points, but the use of CBT as low as diagnostically acceptable It used to be as reasonably LRA, but what we really want to stress is, can you see what you need to see? And if you need to take another image, is it going to change your treatment plan? The biggest thing I try to teach a lot of the pre-docs when I work with them is, you might not have the ideal PA or the ideal pan, but if you can see what you need, that's really what matters. And also the practitioner's responsibilities. You're going to be held as a standard as an OMFR radiologist. So make sure that you are taking CE courses, understanding what you see. For documentation, be able to support why you are taking this CBCT. And again, radiation safety and quality assurance, specific policies in place and procedures for dose optimization. So the responsibility, that's the biggest thing. You're responsible for everything within that field of view that you ordered. So understand what you're looking at, and develop a scan method. My first job at 16 was being a lifeguard at Six Flags Water World, at the wave pool. For a 16-year-old, it's pretty stressful. You're scanning the water a lot. You had to come up with your own scan method to make sure you're covering the whole base of everything. So just like this with CBCTs, develop your own method when you're scrolling through these volumes and understanding what you're looking at. If you don't know what you're looking at, phone a friend. There's nothing wrong with reaching out and getting some input from a radiologist. And this person over here decided to move during a CT scan. Symmetry, this is the biggest thing I try to teach the pre-docs or anybody I ever talk to. As you're scrolling through, you really want to understand your anatomy and the normal variations of these anatomies. So there could be some minor differences, but once you understand what normal is as you're scrolling through, you're going to be able to recognize the abnormality that's showing. So it's really important to get that under your belt so that you're able to, whatever pops out, you're able to see it immediately. Again, some normal anatomy CBCT. So I'm going to pull up a CBCT and just kind of go through kind of a scan method that I go through, and kind of identify a few different structures while we go down. Again, we're going to be rushing through a lot of this because I want to get through some cases as well, but at least give you some quick little pointers of what I see and what I'm looking for. Just for a baseline here, we have our axial view up here in the left corner, our sagittal view in the upper right corner, and our coronal view, and then we have a volume render. Again, it's just like looking at a pan when you're shaking hands, right goes to the right side. So we've got a nice CBCT here. Most of the time I like to go into a pan mode first, just to get just an overall view. Is there anything going on with this patient that I need to identify? If this is a CBCT coming in for a specific reason, I tend to go straight to that area first, write what I know and what I'm seeing, and then I will go through my scanning process. So just going in, axial is my favorite view to start in. Up in this top corner here, you've got different ways you can do your layout. So if you want the coronal to be larger or the axial to be larger, this way I get a better view of everything going on. So as you're scrolling through here, obviously we're just trying to check that frontal sinus. You can see along here. And as you scroll down, and right here, you can see we've already found one incidental finding. Nothing super concerning, but this was a nice, well-defined radio hyperdense entity here, which is indicative of an osteoma. I put it in my report, but again, it would be something very benign that wouldn't be very concerning. As you're scrolling down, obviously you can see the orbit forming the anterior ethmoidal air cells, kind of looking around for that optic canal and the superior orbital fissure going on here. As you get further down, you start seeing the sphenoid sinus, zygomatic arch, the malar. And you can see some mastoid air cells forming up back here in the posterior aspect. And start seeing that maxillary sinuses with the turbinates forming. You also see your coronoid process, your condylar heads, And when we get through some cases that we get are TMJ cases, then we can also utilize the TMJ bar menu here. So when you're coming up to the TMJ area, you do have to set the volume to what you're looking at. And from here, you get like a nice axial view of the condyles, and as well as some sagittal slices or coronal slices, depending on what you're looking for. So this was a TMJ case. They were concerned about anything. You can see maybe a little mild osteophytosis forming on the left condyle. But overall, nothing too concerning. A little flattening on the left condyle as well. And as well as you want to scroll into some coronal slices here, you can start seeing a little more of that flattening. So again, we're looking through the sinuses. I love looking at sinuses first, seeing if there's any airway issues as well, making sure there's nothing impeding into the airway, any pathology imposing on the soft tissue, displacing it. And again, scrolling all the way down, making sure there's nothing going on through the mandible. And again, you're responsible for everything in here. So if you see some arthritic changes and the cervical spine, as you can see here in the sagittal view, just want to take note of it. Again, it's common to get some degenerative changes as you get older, but you still want to make sure that it's at least identified. Here you can see a very common incidental finding, the pineal gland calcification. You got your nice sella turcica and your clivus coming down. And as we scroll through the coronal view as well, you get a nice different perspective of the inferior orbital rim with the inferior orbital canal forming. Get a nice view of the maxillary sinus. You can see a little mild thickening of the mucosal layer. Nothing concerning, but again, something to document. And as you can see too, the IAC as it's forming all the way up to the mandibular foramen and coming all the way down to the mental foramen. So again, anatomy is like the foundation of radiologic interpretation. So understanding that is going to help you identify pathology, because some pathology is more prominent in these certain areas. So applications of cone beam CT imaging, implant imaging and treatment planning, orthodontic application, airway assessment, pathological findings, TMJ imaging, periapical and periodontal findings, developmental abnormalities, and third molar and canal relationships. Today, we're going to focus just a little more on implant planning and some concerns. You know, the biggest areas of concerns are going to be that nasal floor, the incisive canal, the maxillary sinus, the mandibular canal, the mental foramen, the submandibular fossa, as well as the mylohyoid ridge. Again, some anatomy here. You're looking at that hard palate, the nasal floor, and you can see obviously the implant decided to go right into the nasal cavity. The incisive canal, nasal palatine canal. The maxillary sinus, something we want to be cautious of as well. As you can see, this nice implant floating away. Nice volume rendering and crop panoramic image of the implant placements. What's nice about this is being able to identify where that IAC, and you can trace it in the software so that you're able to stay clear from that. And the mental foramen, as well as the submandibular fossa. This is the biggest thing. I see a lot of cases where clinicians think that, yeah, the pan shows good bone, we'll be fine, we'll place it. And of course, you're not recognizing that that submandibular fossa is present, and some patients, it's even more prominent than other patients. So this is for radiology wise, what we would do is usually send out these types of images for any implant planning, giving some nice measurements. that you at least get a ballpark. We still tell the clinician, obviously, when you start planning it yourself and placing these implants, to please be aware of the type of slice we give you could be a little different than what you're looking at. So these measures are really just a good ballpark of what you could probably play with. And then once you are actually defining it, then in this tab here in the implant area, that's where you're able to really check the measurements. And again, this is why we push hard for surgical guides so that it's nice, clean treatment planned. Language of interpretation. So just like anything, once you understand the language, this really goes a long way of being able to identify or at least put you in a certain differential category so that you're able to narrow your differentials. So what you're going to do is you describe what you see. You got to know that location and distribution, that shape, the size, the margin characteristics, the radiographic density, the internal architecture, the effects on the surrounding tissues. So the tooth associated, is it associated with the crown like a CEOT? Or is it associated with the root like a rarefying osteitis? Is it intraradicular like a lateral periodontal cyst? Is it below or above the IAC, which kind of defines if it's odontogenic above the IAC or below, which would be non-odontogenic. Right here, you see a nice Staffney defect. A lot of people might think this is a cyst, but this is what we'd say a pseudocyst, and it's just a defect depression on that mandible. Is it localized or generalized, monostotic, affecting one area, or polystotic affecting multiple bones? Is it unilateral, bilateral? Here you see a nice case of chirubism. The shape and size. So is it small and regular, smooth, round shape like these odontomas? Is it more oval shaped and like the simple bone cavity? Is it scalloped? As you see, the lesion scallops along the roots. There's no root resorption. Is it a moderately to large lesion like this ABC? You can see some severe horizontal root resorption going on for this ameloblastoma, sorry. And then this one's a very large lesion. This is an aneurysmal bone cyst. You can see the large expansion. The margins are characteristic. That again, is it well defined, non-corticated, or is it ill-defined and has this blending border? So again, usually benign lesions are going to have that well-defined narrow zone of transition, smooth, regular, corticated. Those are things you're looking for in a benign category. Once you start getting more to the ill-defined, the wide zone of transition, irregular, ragged, moth-eaten, that's when you're going to start worrying about possibly a malignancy going on. Is it blending, as you see here, apical sclerosis going on? Nice blending border. You can see the etiology. And again, is this a scalloped large lesion? The internal architecture, is it radiolucent? Or is it radiopaque or hyperdense if it's a CBCT like this dense bone island? The number one case I get a lot from my colleagues or my friends from dental school are dense bone island cases. They can be pretty large and they can cause root resorption. Are they mixed density again like this CEOT, Pinborg? I believe he said that if you wanted a lesion named after you to make the lesion name very long, which is a calcifying odontogenic, epithelial odontogenic tumor. So most people might call it either a COT or a Pinborg. Is it unilocular? You got a nice OKC here. You can see that displacement of that third molar up to the ramus. Nice, well-defined corticated borders, scalloping roots. Or is it multilocular as this glandular odontogenic cyst? Does it have a cotton wool appearance? A nice case of Paget's disease. Or does it have more of an orange peel ground glass appearance like fibrous dysplasia? Again, fibrous dysplasia can cause expansion. So again, for benign lesions, you tend to be a little more radiolucent, maybe mixed radiolucent and radiopaque. But malignants are always radiolucent except for metastatic breast and prostate cancer, osteosarcoma, and chondrosarcoma. So the effects on the surrounding structures, you can see here, nice horizontal root resorption caused by an ameloblastoma. That's a very hallmark sign for ameloblastomas. Is there PDL widening, lamina dura, sclerosis or resorption? Are you seeing any displacement of that mandibular canal here? And the fact that this is being displaced superiorly would make me think it's more of a non-odontogenic lesion, non-tooth related. Again, nice fibrous dysplasia. You see some displacement of that maxillary sinus floor, as well as the buccal aspect of the alveolar ridge. And again, this is a really good case of fibrous dysplasia. And is there erosion? And you can see here, this is a very nice image of erosion of the maxillary sinus floor, or of the alveolar ridge and the sinus floor, squamous cell carcinoma. Once you've got that, then you can start putting those in types of disease categories. Is it a cyst, a benign neoplasm? Is it a malignant neoplasm, inflammatory, bone dysplasia, vascular? Is it metabolic? Is it trauma? These are the main disease categories. There is a category for developmental, which could be a very lengthy discussion on another series. So case one, this is a patient actually came to my office with some sensitivity on tooth number 3. There were no signs of caries. There just nothing was really present that I could see. So I said, maybe we could do a small field of view CBCT. Maybe it'll show something. I always tell patients that it's a possibility that nothing shows at all. But of course, we did a nice CBCT, and you can see here we've got internal cervical resorption. When it comes to internal resorption, it's idiopathic. There's a lot of reasons, but they're not very clear what it could be. Could be orthodontic, could be trauma. So this is a nice case where CBCT worked very well in our favor, that we were able to see it. Patient went and got endo treated, came back a month later, no symptoms, no issues at all. Case 2, this is a nice crop panoramic of an image. And again, we're just going to go down this radiographic appearance and the location distribution. You can see here originating from the CEJ. That's a huge hallmark associated with the crown of tooth number 32. Sorry, missed that there. So superiorly along the external oblique ridge. The shape is going to be nice, oval, smooth, balloon cyst-like. The size is going to be a medium size, small. Margin characteristics is well-defined, corticated. The radiographic density is radiolucent. The internal architecture is going to be unilocular, and the effects on the surrounding tissue, you can see that the mild inferior displacement of the IHC, the inferior displacement of tooth number 32, and a superior displacement of that alveolar ridge. With all that information, especially again with that hallmark originating from the CEJ, we're going to put this more into a disease category of cyst. Again, trauma, inflammation, cyst, tumor, benign versus malignant, fibroosseous lesions, systemic and metabolic or developmental. And with cyst, we're definitely going to go with dentagerous cyst, because again, hallmark forming from the CEJ. Now, these other differentials, hyperplastic follicle, OKC, ameloblastic fibroma, this image alone would not warrant these types of differentials, but they can be, if they're smaller, if this lesion was smaller, these would be some good differentials to go with it. Odontogenic keratosis, OKCs, they tend to have more of a tunneling appearance, not much buccal lingual expansion going on, while this dentigerous cyst, obviously you can see a lot more expansion, especially along that external oblique ridge. Hyperplastic follicle, a lot smaller, you're going to see an ameloblastic fibroma. You just don't see them very often, but they tend to be a little smaller in some areas. Management is going to be surgical removal. And case 2, we got a PA of this endo-treated, or not endo-treated, but lower right pain. So we took a evaluation of the 5x5 field of view to evaluate tooth number 30. And again, nice view here. We can see in the axial some lingual cortex destruction, expanded from tooth number 30 almost to the mesial aspect of the root 31. radiolucent, non-corticated, sclerotic borders around the area, sclerotic as well. As you're scrolling through the coronal, you can start to see that it's in close proximity to the IAC. And you can still see a nice cortical border around the IAC, but a lot of destruction of that lingual cortex. This ended up, we did recommend a biopsy just the size of this lesion. And you can see in the sagittal view. One other nice thing that we like to utilize this software for is endo. So here you get to select that tooth that you're looking at, and we'll make this kind of nice and quick here. And with this, the axial view is one of my favorite views that I utilize with this. And again, you can start tracing the canals as well as the distal canal. Lateral view is a little works pretty well. I like the lateral view more on single rooted teeth. But again, these are great images that, especially with possibly missed canals on the upper molars. We get a lot of those cases where we can trace the canal out for the patient. So again, location and distribution involving tooth number 30 and the medial root of tooth number 31 extending to the lingual cortex with erosion. The size is a medium size. Margin character is mostly defined non-corticated sclerotic borders. Radiographic density is radiolucent. And effects on the surrounding tissue, you can see the erosion of that lingual cortex, close contact with the IAC. And the disease category, they did end up doing a biopsy. It was inflammatory, a rarefying osteitis in radiological terms. They ended up endo-treating it. All right, case number 3. This is a good case of incidental findings on a CBCT. As I said before, anything you take is always you're responsible for. So patient came in, and as we're going through, again, checking those sinuses, and right there here on the left maxillary sinus, you see a nice, well-defined dome-shaped soft tissue density. Indicative of mucus retention pseudocyst. And again, big reason it's pseudo is it's not a real cyst. It's not lined with epithelium. So this is one incidental find I would definitely put in our reports. And as you're scrolling more inferiorly down, you start to see some really nice calcifications of the carotid. This one's just out of the field of view a little bit, but this one's a real nice ring that you can see. And as you scroll back up, and we'll switch to the coronal view. You'll start to see some intracranial calcifications of the carotid as well. So again, lesion 1, we saw well-defined non-corticated soft tissue density, dome-shaped, indicative of mucus retention pseudocyst. On lesion 2, we saw those defined bilateral hyperdense lesions within the carotid space, indicative carotid calcifications. And then again, at the end, we saw this nice intracranial portion of the right and left internal carotid arteries. So while those findings aren't associated with increased risk for stroke, it may point to some generalized cardiovascular disease. So again, very important to recognize these incidental findings and put them in your report, or at least let the patient know to talk to their primary care physician. All right, case 4. Nice panoramic image here. You can see a nice large lesion on the left ramus area. So of course we have a nice CBCT for this. And as we always do, I do like going to the pan first, but since we've already done that and you've seen how it looks, we'll focus a little more on these different orthogonal views. As you're scrolling down into the ramus area, you can start to see, if you look bilaterally, you can see nice well-defined borders. As you start to scroll down, you don't see that as much on the left side. You do see some buccal and lingual expansion going on. Let me just increase that contrast a little more, see if I can get those to show up. So one thing to note, sometimes even though you might not see the cortex, doesn't mean it's not full, that it's not intact, that there's erosion or something. Sometimes it's average voluming, so it might be just thin enough where it doesn't show up on the CBCT. So there could be some perforation going on, but you can still make out the lesion. And you can also look at that soft tissue expansion going on that left side as well. The chrono view gives you a good visualization of it as well. So as we're scrolling further back, you start to see that expansion going on. And you see some very fine septae within it. Also, another incidental finding going on here, you can see some active acute sinusitis. You see the nice little air bubbles forming within bilateral those sinuses. And one other feature I tend to do a lot with is these custom slices, so I can get a nice sagittal view of what I'm looking for. And we can scroll through this as well. All right, so basically this is what you would get in a radiology report. Obviously, we didn't break everything down like we did previously, but again, you see a nice radiolucent lesion in the left posterior mandible extending from tooth number 19 up the ramus. Margins are mostly defined, partially corticated, sparse and faint internal septae are noted. Tooth number 18 is displaced and shows mild root resorption. There's definitely some buccal and lingual expansion. The mandibular canal cannot be seen, but except for the inferior portion of the middle of the lesion. So you can see back here this nice little IAC. So this was an ameloblastoma, benign odontogenic tumor. Differential diagnosis was an ameloblastoma, very hallmark size. The management, we did a CBCT, the biopsy, and of course they do an excision and resection. And again, one of those incidental findings we saw was acute sinusitis. Usually with chronic sinusitis, here you can see in this axial view, you get a lot of thickening of that maxillary sinus borders. Sometimes you'll get some calcifications going on within the mucositis as well. All right, this is one of my favorite cases. So Tony Montana presents with a chief complaint of nasal drip. So we got a nice panoramic image here just to kind of get an idea what's going on. And obviously up here in this maxilla area, we can see that there is something missing. So right here off the bat, off this axial view, you can see that there's just complete erosion of that nasal septum, those lateral walls of the nasal cavity. Part of the maxillary posterior border is sclerotic and eroded. You can see in the nice sagittal view, the hard palate's completely gone. That soft palate is just hanging out there. And you can just see that there's just complete erosion of that maxilla, and then in the coronal view as well. So yes, this is a great drug abuse case that I've seen. I've seen nasal septums obliterated, but not to this extent. So again, drug abuse, vasoconstrictor, destructive erosion of the maxillary sinus walls, hard palate nasal septum, and the treatment plan was they ended up doing a palatal obturator in the pros department. Case 6, this is a nice classic sign of bisphosphonate usage. For time's sake, we'll go straight down to the mandible. As you're scrolling down, you can start to see some sclerosis, some sequestral bone going on, some peristeel reaction going on, that new bone forming on the side to prevent that infection going further out or that inflammation going further out. This is why one of my first questions I always ask for extractions are, have they been on bisphosphonates? Have they been on any blood thinners? As you're going through, you can see in that right mandible, some nice sequestral bone going on. And again, you can see that peristeel reaction comparing again to that left side versus the right side. And this is where I was talking about earlier, of always having that bilateral, looking through things, looking for that symmetry. So in that multiplanar view, you can see that mandible shows mixed density changes dominated by sclerosis. The lingual cortical plate is discontinuous and isolated. Radiopaque masses are indicated as sequestral bone. And the disease category, metabolic and inflammation. And additional information you want to obtain, obviously we know it's bisphosphonate case right now, but does this patient use any bisphosphonates? The patient have a history of radiation treatment, conservative antibiotics and sequestrectomy, and debridement is going to be the case management for this. And this is the company, the reading service I work for, Capture 3D Radiology. You can use that QR code, take a picture of that. If you ever have any questions, don't hesitate just to reach out, even if it's just a quick image or something you want to look at or talk about anything. I love educating. It's one of my favorite things to do. Hoping to start adjuncting at UNC when I can. I still work with the pre-doc students on Wednesdays. So don't hesitate. And that's all I have for you. Right under an hour.
Good timing. Thank you, Dr. Koroni. We appreciate all of this. Let me share my screen again. We are open for any questions right now. If you have them, go ahead and drop them into the Q&A box. I do already have one, Dr. Koroni. Is there a standard of care associated with CBCT imaging?
Yeah, with the standard of care, I mean, the biggest thing is that executive opinion paper we went through. You really want to have a reason why you're taking these images, and hopefully either ruling something out or ruling something in. So getting the smallest field of view if possible is always a nice thing. And again, going by as low as diagnostically achievable is really the main goal.
Awesome. Thank you. Does every case need to be sent to a radiologist?
I mean, not every case needs to be sent. If you know, as a general dentist, you're obviously able to do whatever you feel comfortable doing, being held to that standard of that specialty. So if you feel comfortable and you got a nice small field of view of an endo case and there's nothing going on, or you feel like there's nothing, then of course you don't need to send that case. But I know as a general dentist, time is production. So if you have the time to go through these cases and those CBCTs, great. Most of my colleagues don't have the time to go through that, and they tend to send them out to myself or another radiologist. And it helps kind of in some ways cover you, making sure that there isn't anything you missed in those field of views, especially some people that like to take CBCTs for ortho cases and getting these large field of view. So it definitely makes things a little easier and peace of mind as a general dentist to make sure that everything was covered and there's no pathology existing before they start orthodontic treatment.
Okay, sounds good. Thank you. We do have a thank you for the good information. We do have another question. As a radiologist reads the image, I think they're trying to say, how do we change the transparency of the image for better reading? Is that your question?
Yeah, so if you're trying to change like the contrast, through this software, there's a tab on the left side where you can change that contrast and brightness. So if you need something to stick out a little more or a little less, and you're trying to focus on, obviously CBCTs, we really focus on bone window. So you're going to see some light soft tissue expansion, but if that's what you're looking for, there's definitely some settings on that software that you can change that contrast and get a little better visualization of what you're looking for.
Okay, thank you for that one. Do you have another one? We shouldn't diagnose based on 3D VR renderings. Or
should we or should we not diagnose on 3D renderings?
I think so. Mm-hmm.
I mean, when it comes to on the radiology side, obviously our goal is to give you as close of a differential that we can of what we think it is. Again, like cemento osseous dysplasia. Do you need to refer that to a oral surgeon? No. If we're able to diagnose and tell you exactly what it is, then some things don't need to be, the Pandora's box does not need to be open. So there's definitely things that we can give you a solid differential. Then there's some that we will say, yes, you need to send this to a biopsy or take a biopsy and send it out.
Okay, thank you. And then finally, we have another one. What is the PACS system to integrate with in vivo software? I can actually answer that one for us.
Yeah.
So we can integrate with any PACS system as long as we have the AE title and the IP address associated, and you have it in your same ecosystem of softwares. Would you like to speak on some endo cases, Dr. Koroni? We already have a request for you to come back.
Oh, yes, I will definitely speak on some endo cases, especially since that is from my father. Yes, we will definitely. I'd love to do a case, a C on just endos and different types of pathology you're going to see in a small field of view.
Great. Well, can't wait to have you back for sure. All right, I think that's all of our questions. I do want to say thank you, Dr. Koroni, for putting this together. It's been a pleasure working with you on this. Even bigger thank you for all of our attendees that are joining us live today. If you have any other questions for Dr. Koroni, you can send them to us. We can pass them along. And if you have any suggestions for future content, like the endo cases, be sure to send that to us as well. We look forward to hearing from those. And thank you again. Have a wonderful rest of your Friday and a great weekend.
All right. Thanks, everyone, for showing up. Have a good day.